Usually when we talk about the body's alarm systems, we're talking about things that actually work.
Right. They're supposed to.
You touch a hot stove, you pull your hand back, it's immediate. You get a chest infection, you start coughing, there's a signal.
A clear cause and effect.
Exactly. And even with some of the scariest diagnoses we cover, there's often some kind of preamble, a lump you can feel,
Hmm.
a mole that changes color.
Mm-hmm.
Something that just waves a little red flag and says, hey, pay attention, something is wrong here.
It's a form of biological courtesy, in a way. The body's trying to save itself.
That's a great way to put it.
Right.
But then there's the pancreas, and specifically pancreatic cancer. It doesn't seem to believe in warnings.
No courtesy at all.
It doesn't wave a flag. It hides. It grows in the dark. And the terrifying reality, and this is why we're doing this deep dive today, is that by the time it finally decides to announce its presence, the conversation is, well, it's often already over.
It's the ultimate stealth predator of pathology. I think that's really the only fair way you can describe it.
It's a stealth predator.
Yeah. It exploits the body's own anatomy, its own silence, to do its work completely undetected.
And that is exactly what we are going to unpack today. We are not just going to list off symptoms you can find anywhere online.
No, this is different.
We want to look at the system of this disease.
Right.
We're going to be detectives here. We want to understand why it's so feared, how it starts, physically, on a cellular level, often years before anyone knows, and why it is just so notoriously difficult to catch.
And to do that, we're sticking to the heavy hitters. We're basing this whole analysis on high-yield medical literature, specifically referencing, the gold standard of pathology, Robbins.
So we're going straight to the source.
We are. We're looking at the hard science, the molecular biology, and the really grim statistics that define pancreatic carcinoma.
Okay, so let's set the stakes right there. We all hear about breast cancer, lung cancer, prostate cancer. They have awareness months, ribbons.
Right, they're part of the public consciousness.
Where does pancreatic cancer really sit in that hierarchy of threats?
Well, it sits very, very near the top in terms of pure lethality. If you just look at the raw numbers, it's the third leading cause of cancer deaths in the United States.
The third. That's higher than I think most people would guess.
It is, and that alone is a staggering statistic. But, rankings don't really tell the full story. The number that really stops you in your tracks, the one every medical student remembers forever, is the 5-year survival rate.
And what do we look at?
It's hovering right around 10%.
10%.
Yeah.
So you're saying for 90% of people who get this diagnosis, they won't see that 5-year mark.
Yeah.
Honestly, it's hard to process a number like that in modern medicine.
It is devastatingly low, and that number has been so stubbornly difficult to move. We really have to ask why.
Right. Why hasn't that number jumped up like it has for, say, certain leukemias or breast cancer, where we've seen these massive strides?
The answer lies in the biology we're going to discuss. It presents late because it grows in a huge anatomical space, the retroperitoneum, that lets it expand without hitting pain fibers right away.
So it has room to grow silently.
A lot of room. And it spreads early, often before the main tumor is even big enough to see clearly on a scan. And then there's the surgery problem. It is remarkably difficult to remove surgically.
Why is that? Just because of where it is?
Exactly where it is. It sits tangled up with all these vital arteries and veins, like the superior mesenteric artery and vein. It's not a simple scoop-it-out situation.
So it's not just a tumor in the way we traditionally think of one, where you just go in, you resect it, and you're done.
No, you really have to frame this differently. Robbins describes it in a way that I think is essential for understanding the gravity here. You shouldn't think of it as just a localized lump.
Okay.
You should really think of it as a late-detected systemic disease.
A systemic disease. Meaning, by the time you found it, it's already a whole body problem.
Precisely. By the time we can physically see it, it has usually already engaged with the rest of the body in a pretty catastrophic way.
Wow, that is a heavy way to start, framing it as systemic from the get-go, but I guess it's necessary.
I think it is. It sets the stage for why this battle is so incredibly uphill.
Okay, so let's rewind the clock then.
Yeah.
If this is a late-detected disease, it has to start somewhere. It doesn't just appear out of thin air, fully formed, right?
It does not. And this is where the science has, really advanced in recent years. We used to think it just sort of exploded onto the scene. We now know that pancreatic cancer has an origin story, a prequel, if you will.
A prequel, I like that. The invisible beginning.
Precisely. The term you absolutely need to know, and this is a big one in pathology, is pancreatic intraepithelial neoplasia, or, for short, PANIN.
PANIN, P-A-N-I-N. Okay, let's break that down. What exactly is a panning lesion?
So imagine you're looking at the pancreas under a super high-powered microscope. You see these tiny, tiny ducts that carry digestive enzymes. They look like little pipes. Pennins are microscopic lesions that form inside the lining of those very small ducts. You cannot see them with the naked eye. A surgeon could open a patient up, hold the pancreas in their hands, and it might look and feel completely normal from the outside.
But inside?
Inside those microscopic ducts, the cells are already starting to change. They're going rogue.
So these are the seeds, the very, very first seeds of the cancer.
They are the seeds. And the data from Robbins is crystal clear on this. More than 90% of invasive pancreatic cancers arise from these precursor lesions. They are the biological starting point.
And if they're microscopic, how do we even know they're dangerous? I mean, what's actually happening inside those tiny cells that sets this whole horrible train in motion?
That's the million-dollar question. And it comes down to the genetics. Even at this invisible microscopic stage, the cells are undergoing a dramatic biological failure.
Failure.
Yes. And one of the specific early genomic events that the literature mentions is dramatic telomere shortening.
Telomeres. Okay, I've heard of these. They're like the protective caps on the ends of our DNA chromosomes, right? The analogy is always the plastic tips on shoelaces.
That is the perfect analogy. Those little plastic tips, the aglets, they keep the shoelace from fraying and unraveling.
Right.
In our cells, telomeres do the same for our DNA, but in these Pancreatic lesions, for a variety of reasons, those plastic tips are being worn down way too aggressively.
And what happens when they get too short?
When the telomeres shorten too much, the DNA itself becomes unstable. It becomes prone to breaking, to fusing together with other chromosomes where it shouldn't. It starts to mutate. So essentially, inside these tiny invisible ducts, the entire genome is fraying at the edges.
And that instability, that chaos, sets the stage for everything that comes next. That's fascinating and terrifying. That this whole lethal process starts with something so small and undetectable. It's like a single microscopic glitch that eventually crashes the entire system.
That is the literal definition of the invisible beginning. And the tragedy, of course, is that we don't currently have any way to screen for panions.
You can't see them on a CT scan or an MRI.
Nope. Nothing. They are silent saboteurs. We are looking for a forest fire, but these are just the first few sparks in the underbrush, totally invisible to us.
Okay, so we have these microscopic seeds, these pennins, brewing in the background. But who is walking around with them? Who is most at risk? Is there a typical profile for someone who develops this cancer?
There is, very much so. If we just look at the demographics, this is primarily a disease of older adults.
Okay.
Approximately 80% of all cases occur after the age of 60.
So it's fundamentally a disease of aging. The longer you live, the more time there is for these things to go wrong.
Generally, yes. The typical profile is an elderly patient. But we have to look at why that is. It's not just the passage of time. It's what happens over that time. It's about the accumulation of damage. We have to talk about environmental triggers.
The external factors. So I assume, like with so many other cancers we talk about, lifestyle plays a big role here.
A massive role. You ask why? And the strongest, most unequivocal answer we have from an environmental standpoint is cigarette smoking.
Smoking. Of course. It seems to come up in almost every deep dive on pathology we do. Lung cancer, bladder cancer, heart disease, and now the pancreas.
It is the usual suspect, but the correlation here is just so stark. Smoking doubles your risk of pancreatic cancer. It is, without a doubt, the strongest environmental influence that we have identified.
It doubles the risk. That's a huge number. So why? How does smoking affect an organ that's deep inside your abdomen? It's not like the smoke is touching it.
No, but the chemicals are. Carcinogens from the smoke, like nitrosamines, are inhaled, they get into the blood, and then they circulate throughout the entire body.
Right.
And the pancreas is a secretory organ. It's constantly pulling things out of the blood to make digestive enzymes. So it ends up concentrating these carcinogens right in those ductal cells.
Right where the pancreans start.
Exactly where they start. So you're literally bathing the lining of your pancreatic ducts in poison.
That's a vivid way to put it.
Yeah.
You're creating the perfect chemical environment to accelerate that telomere shortening and DNA damage we just talked about.
Yeah. You're throwing gasoline on the sparks.
Okay, so smoking is number one. What about other things? Diet, other health conditions. We hear so much about sugar and fats and inflammation.
Well, those are definitely factors. Chronic pancreatitis, which is long-term, ongoing inflammation of the organ, is a significant risk factor.
Because the cells are always dividing to repair the damage, so there's more chance for an error.
Exactly. More cell turnover, more risk. Visceral obesity, so a high BMI, especially carrying weight around the midsection, that also increases the risk. But there is one more risk factor, or maybe it's better to call it a clinical clue that I really want to highlight.
Okay.
Because it is a massive aha moment for any physician or any person watching for this disease.
I love an aha moment. What is it?
It's all about diabetes mellitus.
Diabetes.
Yes. Now, long-standing diabetes, like type 2, is a modest risk factor in itself, but that's not the red flag. The real red flag, the one that should make your ears perk up, is new-onset diabetes in an older patient.
Wait, hold on. Let me clarify that because it's a crucial distinction. If someone has had type 2 diabetes for 20 years, that's one thing. They're managing it. But you're saying if a 70-year-old who has been pretty healthy their whole life suddenly develops diabetes out of absolutely nowhere, that's the danger signal.
That is the klaxon horn going off. Exactly. If you have an elderly patient who isn't particularly obese, has no family history of diabetes, and all of a sudden their blood sugar goes haywire, that is not just late-blooming diabetes. That is a major, major red flag.
And the logic is that the hidden cancer in the pancreas is messing with the organ's ability to regulate insulin and sugar.
Precisely. The tumor is either physically disrupting the function of the islet cells that make insulin, or it's releasing inflammatory factors that cause insulin resistance throughout the body. Robbins specifically notes that new-onset diabetes can be the very first indication of an occult or hidden pancreatic cancer.
That is such a critical piece of information. It completely shifts the perspective from, oh, Grandpa needs to get back on sugar, to, we need to get a scan of Grandpa's pancreas right now.
Yeah, correct. The rule of thumb in the clinic is pretty clear. Old patient plus new diabetes plus unexplained weight loss, that equals suspicion of pancreatic cancer until proven otherwise. It's the closest thing we have to a warning sign in those very early stages.
Wow. Okay, so we covered the who and the where it starts. Now we really want to get into the how. You mentioned earlier that the DNA starts fraying because of the telomeres. But cancer usually follows a pattern, right? It's not just random chaos. There's a sequence to the madness.
You're absolutely right. It feels like chaos to the patient and the body, but molecularly, it is a very structured, very predictable domino effect. We call it the molecular progression model. And Robbins breaks this down beautifully. It's almost like a step-by-step instruction manual on how to build a killer.
A recipe for disaster. Let's walk through those steps. What's the very first domino to fall?
Step 1 is the ignition. This is a mutation in a gene called KRAS.
KRAS. We hear that name a lot in oncology, especially with things like colon cancer.
Yeah.
How common is it here?
It is almost universal. KRAS activation occurs in more than 90% of pancreatic cancer cases.
90%. That's incredibly high. So that basically means if you have pancreatic cancer, it's almost a guarantee you have this mutation.
It's the defining feature. It's the founder mutation. Think of KRAS as a simple on-off switch for cell growth.
Okay.
Normally, it sits on the cell membrane and waits for a signal telling the cell to divide. It turns on, sends the signal, and then immediately it turns itself off. It's self-regulating.
It knows when to stop.
It knows when to stop. But in pancreatic cancer, this specific mutation creates a defect. The switch gets jammed. It gets stuck in the on position.
So it can't turn itself off.
It can't. So the cell is receiving a constant screaming signal, divide, 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 now.
So it's the ignition key that starts the engine of the tumor, and then it snaps off in the lock.
That's a perfect way to put it. And this happens very, very early. We see this KRAS mutation even in those microscopic panning lesions we were just talking about. The engine is running before the car has even left the driveway.
So the engine is running. The cell's being told to divide constantly. But usually our bodies have safeguards for this, right? There are brakes.
We do. And that leads us directly to step 2, the loss of control. The engine is revving, but normally the cell cycle has checkpoints, and one of the most important brakes is a gene called CDKN2A, which produces a protein called P16.
P16. And I'm going to guess that in cancer, this brake gets cut.
That's exactly what happens. The inactivation of the P16 gene occurs in about 90 to 95% of these cancers. Robbins highlights it as a crucial step. Normally, P16 stops the cell from moving from one phase of its life, the G1 phase, to the S phase, which is the synthesis phase where it copies all its DNA.
So if P16 is gone, the cell just rushes forward into replication without any checks.
It barrels right through the checkpoint. So now you have a car with the gas pedal floored and stuck down. That's KRAS. And the brake lines have just been cut. That's P16.
That's a recipe for a crash. But the cell isn't invasive yet, is it? Just going too fast in one place.
Not yet. It's a benign but rapidly growing lesion at this point. That leads us to step 3, the late stage. And this involves removing the absolute final safety nets. We're talking about the inactivation of two molecular heavy hitters, TP53 and SMAD4.
TP53, that one's famous. It's the guardian of the genome.
It is. TP53 is the cell's ultimate quality control officer. If DNA is damaged, which we know it is because of those fraying telomeres, TP53 is supposed to sense it and trigger the cell to commit suicide, a process called apoptosis.
So it's the self-destruct button. It says, you are broken, you are a danger, you need to die for the good of the whole organism.
Precisely. And in about 70 to 75% of pancreatic cancers, TP53 is mutated and knocked out. The self-destruct button is disconnected.
So the safety net is gone.
Yeah.
The mutant cell is now allowed to live and pass on its damaged DNA.
Exactly. And then you have the final piece of the puzzle, SMAD4, which is inactivated in about 55% of cases. SMAD4 is part of a signaling pathway that normally suppresses growth. When you lose SMAD4, it is very strongly associated with high-grade lesions and, crucially, with invasion.
Ah, so that's the tipping point.
That's the moment the tumor stops just growing in place and starts actively attacking the surrounding tissue. It's when it becomes truly malignant.
Okay, so let me recap the Robbins recipe here just to make sure I have it. You start with KRAS as the gas pedal.
Right.
Then you cut the brakes with P16 inactivation. Then you disconnect the self-destruct button by knocking out TP53.
Yep.
And finally, SMAD4 gets lost, and that's the green light to invade.
That is a perfect synthesis of the core molecular story. That sequence, KRAS, P16, TP53, SMAD4, is the molecular signature of this disease. It explains, from the ground up, why it is so aggressive. It has systematically dismantled every single defense mechanism this cell has. Like a bank robbery where they've disabled the cameras, cut the alarms, and bribed the guards before they even walk in the door.
That's a really good analogy. The job is done before anyone even knows it's happening.
Now, most of this sounds like, bad luck or environmental damage, somatic mutations that happen during life. But what about genetics? Can this be passed down from your parents?
For the vast majority of cases, it's sporadic. It's just what we talked about. But Robbins does note that about 10% of patients have an inherited germline mutation or a very strong family history.
10%. That's not insignificant. That's 1 in 10 people. What are the genes we're looking at there?
The most common known cause, and this surprises a lot of people, is actually a mutation in the BRCA2 gene.
BRCA2. Wait a second. Isn't that the breast cancer gene? The one Angelina Jolie made famous?
It is famous for its association with breast and ovarian cancer, yes. But it is also the single biggest player we know of in familial pancreatic cancer.
That seems completely disconnected. The breast and the pancreas, how does that work?
It's all about the gene's function. BRCA2 is a DNA repair gene. Its job is to fix double-strand breaks in DNA, which are one of the most dangerous kinds of DNA damage. It doesn't care what organ it's in.
So it's a mechanic for the whole body.
Right. And if you have a faulty inherited BRCA2 gene, your cells in every organ struggle to fix these breaks. In the breast, this can lead to breast cancer. In the ovary, ovarian cancer. And yes, in the pancreas, it dramatically accelerates the domino effect we just talked about.
Does knowing this change how we treat patients? I mean, if you have pancreatic cancer, does it matter if it came from a BRCA2 mutation or just bad luck?
Drastically. It's a game changer. The modern recommendation now is for germline genetic testing for all pancreatic cancer patients, regardless of family history.
All of them?
All of them. Because if we find you have a BRCA2 mutation, your tumor has a specific weakness. It has a broken DNA repair kit. We can exploit that. We can use drugs like PRP inhibitors or platinum-based chemotherapy that cause so much DNA damage that a normal cell could fix it, but your cancer cell, with its broken kit, just dies.
So it turns a weakness into a target.
Exactly. It's one of the few real slivers of light we have in terms of targeted therapy for this disease.
That's incredible. Okay, so let's move from the microscope up to the gross anatomy. We all know the pancreas is this weird comma-shaped organ. It has a head, a body, and a tail. Does it matter where the tumor decides to set up shops?
Oh, it matters immensely. In real estate, they say location, location, location.
Right.
In pancreatic cancer, location dictates detection. And detection dictates survival.
How so? Walk me through the geography here.
Okay, so let's look at the breakdown. About 60% of these tumors arise in the head of the pancreas.
The head, that's the thick part on the right side of the abdomen.
Correct. Then about 15% are in the body, the middle section, and only about 5% are way out in the tail by the spleen. The last 20% or so involve the entire organ diffusely.
So the head is by far the most common spot. Why does that matter so much?
because the head of the pancreas is tucked right into the curve of the duodenum, which is the very first part of the small intestine. And crucially, the common bile duct, which drains bile from your liver and gallbladder down into your gut to digest fat. That duct passes physically through the head of the pancreas on its way down.
I see where you're going with this. If a tumor starts growing there.
It acts like a clamp on a garden hose. It starts to squeeze that bile duct shut. This causes all the bile to back up into the liver, and eventually it spills into the bloodstream. And when that happens, the patient turns yellow. They develop jaundice.
So in a very dark and twisted way, getting a tumor in the head of the pancreas is almost lucky because it causes a visible symptom relatively early.
Relative to the alternative, yes, the obstruction from a head tumor can cause symptoms while the tumor might still be pretty small, maybe 2 or 3 centimeters. The patient turns yellow, they feel itchy, they go to the doctor, and we find the mass on a scan. We might, and it's a big might, be able to catch it in time for a curative surgery.
But the body and the tail.
The body and the tail are a completely different and much scarier story.
Why?
Because they don't have that critical bile duct running through them. They are surrounded by empty space in the retroperitoneum. A tumor in the tail can grow to be massive, the size of a grapefruit, invading the spleen, the stomach, the spine, and spreading silently for months or even years before the patient feels a single thing.
Because there's nothing for it to block.
Nothing to block, nothing
Right.
to alert the patient that something is wrong. By the time those tumors are found, it's usually because of pain from nerve invasion or symptoms from distant metastases, and by then, they are almost always incurable.
That's chilling. So the biology of the tumor is the same, but the simple geography of where it grew determines your fate.
It's a brutal reality of the disease. It's hiding in plain sight.
So let's talk about what this thing actually looks like.
Yeah.
If a surgeon were to open someone up and see one of these tumors, what are they looking at?
Well, they describe the gross morphology, and it's not a soft, fleshy lump like you might see with a lymphoma. Robbins describes it as being hard stellate, which means star-shaped with little tendrils going out gray-white and very poorly defined.
Hard and poorly defined. Why is it hard? Is it calcified or something?
No, it's not calcium. That hardness is one of the absolute hallmarks of this disease. The tumor creates something called a desmoplastic response.
Desmoplastic. Okay, let's unpack that term. It sounds structural.
It is. Basically, the tumor cells are very good at stimulating the normal cells around them, fibroblasts, to create an intense, dense, scar-like tissue all around the cancer. We call this desmoplasia, or the stroma. The cancer cells themselves are just a tiny fraction of the tumor's mass. The rest is this thick, fibrous scar tissue.
So it's like the tumor is building a fortress around itself out of scar tissue.
That is exactly what it's doing. Imagine pouring concrete all over the cancer cells. That's why it feels rock hard to the touch during surgery.
And that fortress, I'm guessing that makes it incredibly hard to treat.
It's a massive, massive problem. That dense stroma is so thick that it collapses the blood vessels inside the tumor. This makes the tumor hypoxic, meaning it's low on oxygen. But more importantly, it creates a physical barrier.
A barrier to what?
To chemotherapy. Chemo drugs travel through the bloodstream. If the blood vessels inside the tumor are crushed shut by all that scar tissue, the drugs can't get in to kill the cancer cells.
It's building its own bomb shelter. That explains the resilience of the disease. We're throwing medicine at it, but it's literally just bouncing off the walls of this fortress.
Correct. The stroma isn't just a bystander, it's an active participant in the cancer's defense system. Researchers are desperately trying to figure out how to break down that wall so our drugs can actually reach their target.
You mentioned earlier that it spreads early. So how does it get out of this fortress? If it's encased in concrete, how does it invade?
It's incredibly aggressive. It finds the paths of least resistance and exploits them. Robbins highlights 4 main highways of invasion that make surgery so often impossible, or what we call unresectable.
Okay, what are those highways?
First, and I think this is the most gruesome one, is perineural invasion.
Perineural. So around the nerves?
Yes. The cancer cells literally wrap themselves around and grow along the nerve sheaths. They use the nerves as a physical track, like a railway line, to travel out of the pancreas and deep into the abdomen, back towards the spine.
That sounds unbelievably painful.
It is. This is the primary cause of the severe gnawing back pain that these patients eventually feel. The cancer isn't just pressing on the nerves, it is physically invading and strangling them. And because nerves are so hard to cut out completely, this is a major reason why surgeons often can't get clean margins and the cancer comes back.
Okay, that's one highway. What's the second?
Vascular invasion. It does the same thing with blood vessels, burrowing into arteries and veins. This allows it to enter the systemic circulation and seed distant organs with metastatic cells.
Then I assume the lymphatic system is another route.
Correct. Lymph node spread is extensive and happens early. It hits the nodes around the pancreas, the stomach, the intestines. It just moves through the lymphatic fluid very, very quickly.
And finally, once it leaves the neighborhood, where does it go? What are the common sites for metastasis?
The most common sites by far are the liver and the lungs.
The liver. Why the liver specifically?
It's pure anatomy. The blood from the entire digestive system, including the pancreas, drains into a single large vessel called the portal vein.
And the portal vein goes where?
Straight to the liver. It's a direct pipeline. So the pancreas dumps its blood and any cancer cells floating in it right onto the liver's front door. The liver is the first filter.
It really is a perfectly designed enemy. It builds a fortress, travels along nerves to cause pain and escape, and has a direct highway to liver.
It is a formidable opponent. It seems to anticipate every move we make against it.
So let's pivot now to the patient experience. We've gone through the deep biology, but what does the patient actually feel? We've called it the silent killer, but eventually it must show some signs.
Eventually, yes. But like we said at the start, when it finally speaks, it's often speaking way too late.
And pain is usually the first thing people notice, right?
It's often the first major symptom, yes. But think about the tragedy in that statement. Pain, especially that deep back pain, implies nerve involvement.
The paraneural invasion we just talked about.
Exactly. By the time a patient feels that gnawing pain radiating to their back, the cancer has likely already escaped the pancreas and invaded the nerves and the retroperitoneal space. It's usually a sign that the cancer is already unresectable.
And then there's jaundice.
Yeah.
The yellowing of the skin and eyes.
Right, and specifically the term to remember is painless jaundice. This is the classic textbook presentation for tumors in the head of the pancreas. The patient notices they're turning yellow, their eyes are yellow, their urine gets dark like tea, their stools get pale like clay, but they don't hurt.
Why is that distinction, painless, so incredibly important? Why does a doctor care if the jaundice hurts or not?
Because if you have jaundice and it hurts, especially a sharp, colicky pain, it's almost always a gallstone. A stone gets stuck in the bile duct, the gallbladder spasms to try and push it out, and that spasm hurts like crazy.
Okay.
But cancer doesn't spasm, it just slowly, quietly, relentlessly squeezes the duct shut over weeks or months. So painless jaundice is a massive alarm bell for a malignant obstruction.
That makes sense. And that leads us to some of these named signs that are famous in the medical literature. I see Courvoisier sign in the notes here. This sounds like classic medical school trivia.
It is, but it's a piece of medical lore that really holds up in practice. The Courvoisier sign relates directly to what we just discussed. It's the combination of a palpably enlarged gallbladder that is non-tender to the touch, plus that mild, painless jaundice.
So explain the mechanics there. Why is the gallbladder enlarged but not tender?
Because the tumor in the head of the pancreas is blocking the drain downstream, so the bile backs up and it fills the gallbladder like a water balloon, making it big and stretched.
A water balloon?
Right. But because that blockage happened so slowly over weeks, the gallbladder had time to stretch and accommodate the volume without getting inflamed or infected. It's stretched, but it's not angry, so it doesn't hurt when a doctor presses on it.
So if a doctor feels a big swollen gallbladder and the patient doesn't even flinch but they look yellow.
You have to think of cancer. If it were a gallstone causing the blockage, the gallbladder would likely be scarred and fibrotic from chronic inflammation, so it wouldn't stretch well. A big, stretchy, painless yellow patient points to cancer.
Wow. Okay, there's one more sign here that sounds completely wild. Trousseau sign. Isn't Trousseau related to blood clots?
It is. This is also known as migratory thrombophlebitis.
Migratory thrombophlebitis. That's a mouthful. Break that down for me.
Okay. So thrombophlebitis just means inflammation of a vein due to a blood clot. Migratory means it moves around. A patient might get a painful clot in a superficial vein in their left leg 1 week, then it gets better, and a week later a new one pops up in their right arm, then somewhere else. It comes and goes in different locations.
Why on earth would a tumor in the pancreas cause blood clots in the leg or arm? That seems completely unrelated.
It's because pancreatic cancer is one of the cancers that is most famous for creating a hypercoagulable state.
Hypercoagulable, so thick blood.
Essentially, yes. The tumor cells release factors, things like mucins and tissue factor, that get into the bloodstream. These factors activate the body's clotting cascade. They make the blood much stickier and more prone to clotting.
So the blood just wants to form clots more easily all over the body.
Exactly. And this sign, Trousseau sign, occurs in about 10% of patients. And sometimes these weird moving blood clots are the only early sign a patient has that something is wrong.
That is wild. You go to the doctor for a blood clot in your leg, and the root problem is actually a hidden tumor in your pancreas.
It just highlights how truly systemic this disease is right from the beginning. It affects your blood chemistry, your metabolism, your digestion, your nerves. It's total warfare on the body. And a fun fact. The sign is named after Armand Trousseau, a French physician who actually diagnosed himself with what was likely pancreatic cancer after he observed this sign on his own body.
Wow. He saw it himself. Talk about a green discovery. It really puts into perspective why this is such a focus of medical research. Okay, we have covered a massive amount of ground here. Let's try to synthesize this for everyone listening. If we had to boil this all down, what are the absolute key takeaways from this deep dive?
Okay, let's recap the journey. First, you have to remember the origin. This thing starts invisibly as panion lesions, microscopic seeds with those fraying telomeres hiding out in the ducts.
Right, the invisible beginning, and then the genetics kick in to trigger the sequence.
Exactly. The big four genetic hits, KRAS is the ignition, that's 90% of them. The gas pedal is stuck down.
Then P16 cuts the brakes.
And TP53 and SM84 remove the last of the guardrails and allow the tumor to invade.
And then we have the clinical red flags, the things to watch for.
This is so crucial. New onset diabetes in an elderly person, especially with weight loss, that is your line of suspicion. And clinically, that classic presentation of painless jaundice with a big, palpable gallbladder, the Courvoisier sign, that points directly to a tumor in the head of the pancreas.
And finally, the way it behaves, the spread.
Yeah. It creates that fortress of scar tissue, the desmoplasia that blocks chemo, and it spreads along nerves, which causes that terrible pain, and through the blood vessels, often finding its way straight to the liver via the portal vein before we even know it's there.
It is such a heavy topic, but understanding the mechanism, the why, is really the first step in figuring out how to fight it.
Absolutely. And I want to leave the listener with maybe one final thought to mull over.
Okay.
We call this the silent killer, but perhaps it's not truly silent. Perhaps it's just speaking a language that we are only just now learning to hear.
What do you mean by that?
Well, think about the new onset diabetes. Think about the Trousseau sign with the blood clots. The cancer is profoundly altering the body's entire metabolic and chemical state long before a mass ever shows up on a CT scan. The future of fighting this disease probably isn't just in better surgery or stronger chemo.
It's in detection.
It's in detecting those subtle chemical whispers, those metabolic shifts. It's learning to listen for the signs years before the tumor even has a chance to build its fortress.
So we have to become better listeners to the body's chemistry, not just its anatomy.
We have to, because by the time the anatomy changes, as we've seen today, that window of opportunity has so often already closed.
That is a powerful and I think a hopeful place to end. Understanding the enemy is half the battle. Thank you for taking us through the deep science of this, really helping us see beyond just the diagnosis itself.
It's an incredibly important story to tell.
And thank you to everyone listening to this deep dive. Stay curious, stay informed, and we'll see you in the next one.